All right, hi guys. So today we're going to deal with the Ophthal image that was posted as an image-based MCQ on my Instagram handle. So the image and the related things. Okay. So how many of you attended the MCQ, answered the MCQ? Okay, so the image that I had given was this. Okay, so identify the marked clinical finding shown in the image. So on the limbus, you see these gelatinous spots. Good evening, BU. Good evening. Nice, very nice to see you here. All right. So, did you attend this image based MCQ? So, this is the image. Yes, very good. Very good. Good evening, Dr. Vinod. Good evening, BU. Okay. Who's this? Yes. So these are Horner-Trantas dots. Okay. Abhinash, I've got a different answer from you. Okay, Dr. Light, good evening. All right. See, the options that I had given you were Horner-Trantas dots, Herbert Spitz, papillae and follicles, giant papillae and follicles. Hi, music admire. All right. So now the thing is, Flicton is now out of the syllabus answer you have given me. Now I'll tell you also why it is not Flicton and what is the answer. Like, I'm not able to get your name who answered HT spot. HT spot, Hindustan time spot. Yeah. Sorry, Horner-Trantas dots. Okay, so these are Horner-Trantas dots. Hi. See, these are Horner-Trantas dots. Okay, so there are various variations of this that you get. Now, this one, if you see, it is Horner-Trantas dots will appear very gelatinous. Okay, they're gelatinous, elevated nodules, or they are basically limbal follicles. Okay, they're basically follicles which are located at the limbus, and they are it is not giant papillae, because giant, I'll tell you why it is not giant papillae, and why it is not Flicton, and why it is not what is the other one, Herbert Spitz. Yes. See, first of all, your Horner-Trantas dots will be located at the limbus. It can be 360 degrees around the limbus. To start with, it will be on the superior limbus. Most commonly, it is on the superior limbus, but it can be 360 degrees. Okay. So they are elevated masses. They are elevated masses at the limbus, and very often they have a gelatinous character to it. Okay. Now the gelatinous character is basically because of the eosinophil content. More the eosinophils, that means it is going to be more gelatinous. Now sometimes you have whitish dots in the elevated structures. That is basically because the accumulation of the cells, the epithelial debris, that gives that white spots which are not seen in the image that I posted today. But sometimes you get those apical white spots also. Yes. So basically, Horner-Trantas dots are seen in vernal keratoconjunctivitis. What is the other name for vernal keratoconjunctivitis? You have two names. One is the most famous spring catarrh, and the other is warm weather conjunctivitis. Okay. So VKC, you get type 1 hypersensitivity, that is IgE mediated hypersensitivity, and also to a certain extent we also have cell mediated hypersensitivity, that is your delayed type or type 4. Okay, now why it is not giant papillae and why it is not Flicton? Because giant papillae is type 4 hypersensitivity. Okay, and it is an epithelial hyperplasia, but it is mainly type 4. But your Horner-Trantas dots are due to type 1. Okay, type 1, you got a lot of eosinophils. So because of the eosinophils, it gives that gelatinous appearance. Can you see that gelatinous, like gelatin? Can you see the gelatinous? Do you appreciate this? Dennis Morgan fold, I'll come to that, Dr. Light, at the end, okay? I'll come to that at the end, yes? So, on the gelatinous nala, it is a more of eosinophil content is more. So, there is no eosinophil in flictin, there is no eosinophil in giant papillae. Understand? Giant papillae is purely a type 4 hypersensitivity. It's purely a type 4 hypersensitivity. Is that clear? Maybe even type 3, but there is no type 1 or IgE eosinophils and all involved at all. Clear? So it is definitely not flictin. And flictin, you will have it more tinier nodule at the limbus, more tiny, and associated just closer to that, you'll have a lot of redness. That kind of redness is missing in VKC. Okay? And this, when you see Horner-Trantas dots, just gelatinous hypertrophy, limbal hypertrophy, it is the limbal form of VKC. You have a palpebral form, that is where you see all the papillae on the cobblestone appearance on your palpebral conjunctiva when you flip the conjunctiva, no? See the upper tarsal conjunctiva. That is your palpebral form. This is your limbal form. Yes. Now, the limbal form is more common in tropical countries like ours. Yes, that is very, very important. That is why in our patients, we see a lot like this, and especially 360-degree limbal hypertrophy we see. Yes, so it is very common. And when you have limbal hypertrophy like this, because of Horner-Trantas dots, there's also a chance of pseudogerontoxin. Just inner to the nodules, within the limbal area, paralimbal, you'll get a white line. It's a scarring, okay? It's a corneal scarring that you will see on the cornea, like a white line, similar to your arcus senilis. You remember arcus senilis that you see in old people, that white line on the cornea, that white ring on the cornea, which is physiological because it occurs with old age, with senility. Now, this is occurring in young children because VKC is seen in young children, right? So that is why this is called pseudogerontoxin. Toxon means an arc or a line. Toxon. Geronto, geriatrics, geron, that means old age. Pseudo, that means false. It is a false line or a false arc of old age, like arcus senilis. So pseudogerontoxin can occur later because of the subepithelial scarring, which can occur just inner to the Horner-Trantas spots. Now, the Horner-Trantas spots are composed of, as I said, eosinophils and also epithelial debris. Now, the more the eosinophils, you'll get more the gelatinous appearance. When you get the epithelial debris, you'll get that white spots, the apical spots. Sometimes you'll feel like, is that calcified? Those are the epithelial debris, okay? Dead epithelial cells, okay? So, I told you why it is not flictin, and flictin is at the limbus with adjacent a lot of redness, lot more redness, okay? And giant papillae are typically seen in the upper palpebral conjunctiva, in the upper tarsal conjunctiva. What we see on the limbus, we don't generally call it, first of all, as giant papillae, okay? So giant papillary conjunctivitis is what occurs in your tarsal conjunctiva. So when I say tarsal conjunctiva, it is a subpart of your palpebral conjunctiva overlying your tarsal plate. So your upper lid has a tarsal plate, lower lid has a tarsal plate, no? So when you flip your eyelid, whatever is the palpebral conjunctiva just overlying the tarsal plate, that is called tarsal conjunctiva, okay? Now, so as I said, this limbal form of VKC is more common in tropical countries like ours, and because of this lot of itching and this closer to the cornea, what happens is a lot of epithelial thinning that occurs, especially with the eye rubbing that goes on. So many epithelial eosinophils means you got a lot of this itching symptoms. So for the itching, what will the child do? The child will rub the eye vigorously. So that can cause epithelial thinning, corneal epithelial thinning. And corneal epithelial thinning, as I've discussed previously, it is a risk factor for development of a secondary keratoconus. Yes. So what you need to do is always in these kind of patients, monitor them for a secondary VKC. So do a corneal topography. Yes. So how do you, what is the investigation choice for keratoconus? It is corneal topography. So do a topography to detect early keratoconus. Okay. To detect early keratoconus. Spring catarrh இங்கேயும் கொஞ்சம் common தான். It's not, we wouldn't say it's not that uncommon, because you have other elements like dust, then children playing with the dogs and all, no? So dust factor நிறைய உண்டு இங்கே. Although we may not have, and also we have a lot of grass here. Tamil Nadu, no, we have a lot of grass, and grass there is pollen. No, grass or there are the flowers, no. So we may not have the spring, the typical spring of the North Indian, their weather pattern. We may not have something like that, but we do have a lot of pollen in the air, pollen and dust. So that causes VKC. Here, okay. So what was I saying? Yes. So how do you? So is this clear? So this is Horner-Trantas dots. Now Herbert Spitz will not be projecting like this at all. Okay, it will not at all be projecting like this. Yes, it will be buried, flushed with the surface. We'll do that image on another day. Okay, one at a time. So it will be flushed to the surface. Now this one, has it gotten into your head? This one, put in your brain box. Yes. Okay, so treatment is, because as I kept saying, there's a lot of IgE mediated hypersensitivity. So that means there's a lot of histamine release. Yes, histamine is released. That is why the itching. So you have to give antihistaminics, or better, something which has got a dual action, not just antihistaminics. It will also prevent the mast cells from releasing the histamines. That is a mast cell stabilizer, which has a dual action of a mast cell stabilizer and also being an antihistaminic. And what is that beautiful drug? It is olopatadine. You give it as eye drops in these young children. Okay, so that one. Number two, we can give steroids, but we prefer low potency steroids, like somebody asked the other day. So we give a fluoromethalone or lotiprednol. These are the common things that are given. Okay, FML and lotiprednol. That also for a shorter course. Now sometimes, yes, sometimes in practice we might give the stronger ones like dexamethasone, but that will be a very short pulse, okay, because you're dealing with young children who are very, very likely to go into IOP spikes. So the children can develop glaucoma, secondary glaucoma, and also the steroid induced cataract. Okay, steroid induced cataract. So and that can cause amblyopia. Children will not even say, they won't even know. When there's no pain, nobody complains. Yes, so these are something that we have to look out for. Now, is there any other modality of treatment? Yes, we can give for recalcitrant cases. Recalcitrant means something which is not amenable to treatment, which is very difficult to treat. So in that case, we can give something like your calcineurin inhibitors topically. Okay, so we give cyclosporin, which is available as a 0.05% eye drops, cyclosporin, or tacrolimus. Now tacrolimus is available as a 0.1% eye ointment. Beautiful drug. Thoda sa there will be a stinging sensation when the parent applies for the kid, but it works brilliantly. That limbal hypertrophy, this you saw, it will just disappear like magic. Okay, so you can use, what did I say? Cyclosporin 0.05% eye drops, or tacrolimus 0.1% eye ointment. Okay, so topically we can. Now, do we need to give systemic? Now, systemically, generally not needed unless it's not resolving. Okay, so simply don't give the child that I will and all that. Don't give. Okay, very, very rarely, if at all it is not resolving, okay, then we can give montelukast. And you all know what montelukast is. Montelukast is that interleukin 10 inhibitor, no? And also that, and something else I remember way back when I read. Okay, so you can give montelukast, or we can also give that dupilumab. So dupilumab is given especially with to those who have a history of atopic dermatitis. They also have a history of atopic dermatitis. In them, you give the systemic. Especially in them, you give systemic. Montelukast, dupilumab. Dupilumab is what? It is your interleukin 4 receptor inhibitor. No, dupilumab. And also omalizumab. Now, omalizumab is not approved for this indication, but still people do give systemically. And omalizumab is, what is it? I remember this dupilumab. Dupilumab is IL-4 receptor inhibitor. Omalizumab is Interleukin 6, okay, whatever. Okay, omalizumab also can be given systemically, but again, only if there is history of atopic dermatitis and it is not immunoglobulin E antagonist. Correct. Thank you, Dr. Vinod. Yes, omalizumab is IgE antagonist. Correct. So that also can be given. All right. Yes, leukotriene antagonist, and also interleukin 10 also it has an effect, Montelukast. Just check it up. It might be helpful for pharmacology because I remember reading this interleukin 10 because I was reading the pathophysiology, so that is why I remember that. So all these can be tried. Is that clear? Now, this something I said I'll tell you later. Yes, the Dennis Morgan fold is, they'll get us on the skin, they'll get a fold. That is because it's constant eye rubbing, no? So when you rub your eye constantly and very vigorously, there'll be a skin laxity. There'll be skin eczema and a laxity. Because of that, the skin will lose its elasticity. Okay, so there will be a extra skin fold. That is called your Dennis Morgan line. That, yes, in VKC can be seen, can also be seen in atopic keratoconjunctivitis. And what is atopic keratoconjunctivitis, we'll discuss in another day. Okay, AKC is a little more chronic than your VKC. Okay, so I have not discussed the palpebral form yet. I only discussed the limbal form. So palpebral form is where you get your papillae, the typical giant papillae or giant papillae. When do we call them giant papillae? When they are more than 1 millimeter in diameter. Yes. So when you flip, you see those papillae jutting around. So basically papillae are epithelial hyperplasia. The conjunctive epithelial layer, no, they undergo hyperplasia and they're described as pinkish flat topped elevations, your papillae. Yes. So you have a cobblestone or a pavement stone appearance on the palpebral conjunctiva, and there's so much of mucoid discharge that we call it as a ropey or stringy discharge. So if the patient touches that discharge and takes off his finger, it will form a string between the eye surface and the fingertip. Ropey or stringy discharge, characteristically your VKC or spring catarrh. Okay, and when you flip, that mucoid discharge will immediately coagulate on exposure to the heat of the environment. So that is what we call as Maxwell-Lyon sign. So Maxwell-Lyon sign is also seen in vernal keratoconjunctivitis or your spring catarrh. Okay, so anything else that we've not talked about? So what is a complication and what is a mixed form? So one is palpebral form, limbal form. Mixed is you will have both palpebral and the limbal form. And the complications mainly is because of this epithelial thinning that is occurring because of the eye rubbing, and also primarily because of these papillae. Whenever you blink, the papillae are rubbing on the cornea, right? So the epithelium is shown off. Okay, shown means SHOR, and the shearing effect I'm talking about. So what happens is there is a corneal ulcer, because whenever there is epithelial discontinuity, what do we call in medicine? It's an ulcer. Yes, so there is a shield shaped corneal ulcer that develops in VKC. Yeah, and we need to treat it very, very effectively, aggressively, because you can't prevent the patient from blinking, okay, and that touching the cornea. So you have to give them soft contact lens to prevent the lid from rubbing on the cornea. So that, and because that is very much prone to secondary bacterial infection. This, to start with, it is a non-infective corneal ulcer, but then it can soon become infected. So we need to take care of that. And because again of the epithelial thinning, there can be what is called as a secondary keratoconus also in vernal keratoconjunctivitis. Yes, have I addressed all of your doubts or whatever you had commented? So how about giving me some hearts? Abhinesh, Flickton will discuss on another day, okay? So I hope this image is stored in your brain box. At least till the time you move out of MBBS, you clear your NEET PG and INI-CET and move away from us. Yes, so this is Horner-Trantas dots, okay? So completely clear? Yes. Can I have some hearts? All right. Embedded in the hippocampus. Okay, buddy. So that means you're developing some I hope the amygdala is also involved, so you get the limbic memory also there. So every time you think later, even somebody on the in the crowd who's rubbing the eyes, then Dr. Rajarathna comes to your mind, the eye mentor comes to your mind. All right, that's lovely. Okay, all right, wonderful. So I'll see you. Um, Okay, I'll see you soon. And as far as your quiz is concerned, so I will give you a new schedule starting from December 5th, that is tomorrow. So I'll put out the schedule on the Telegram group today. Okay, and the quiz will happen on the iMentor app. Okay, and the discussion also, I'm thinking I'll do a free discussion for you, but on the app. So let's just take a call on that tomorrow. So I hope you're all happy with the discussion. Hi, Siva. All right. I hope you can watch the video and learn. Okay, I'm finishing the discussion for tonight. All right. So see you guys. Ciao, all of you. I hope Ophthal has become interesting. Okay, so my motto in life is spreading Ophthal love. I hope you fall in love with Ophthal. Okay. All right. See you. Bye bye. Good night, all of you. You're most welcome, bache.